So the format, we have more presenters in some of the groups than others. So we'd like to have we'll have the veterinary case of breast cancer first, followed by our human case, and then we'll have osteosarcoma on the animal side presented, and then the human side presented, and then we'd like all four of our oncologists, rather three of our oncologists, 2 human, 1 animal, to sit and discuss these issues comparatively. So we're going to use the same format. After the discussion concludes, we'll open it up for questions. At the conclusion of this session this morning, we're going to again ask that we move quickly, as I said, to grab your box lunches and board the buses. So very excited. To start, we'll have Dr. Robert Rebhun. He is an assistant professor in the Department of Surgical and Radiological Sciences at UC Davis School of Veterinary Medicine. He will be our veterinary oncologist. On the human side, we're going to have Dr. John Glaspy, who is a hematologist and oncologist and professor of medicine here at UCLA. He holds the Estelle, Abe, and Marjorie Sanders Endowed Chair in Cancer Research in the Jonsson Comprehensive Cancer Center here, and we're delighted to have both of them. We'll start with Dr. Rebhun.
Hi, thank you. I'm going to make sure I know how to do this here. So very excited to be here today. I was so excited that they had to give me 2 cases to present instead of just 1. So I get to present both breast cancer and the osteosarcoma. And I am very excited about comparative oncology. It's one of the things that initially got me into oncology, and I think that breast cancer in the dog as well as osteosarcoma are quite good models of disease on the human side, and I think we can learn a lot from human medicine, and I get really excited when we can kind of step in and maybe 5% of the time actually advance in the other direction. So I'm going to have a pretty simple case presentation. It'll be quick. And just to remind everyone, so the latest statistics I had were there are about 78 million dogs in the United States. And a couple other studies looked at what dogs are potentially going to succumb to. Once they reach the age of 10, there's about an overall 40% chance that they're going to die of cancer. In certain breeds, they've actually looked in even lifetime risk. For example, Bernese Mountain Dog, it's about 60% of dogs are going to die of cancer. So that's a lot of dogs that are going to develop cancer. One that isn't particularly very common here in the United States because we do spay is mammary cancer. And so this is actually a 10-year-old intact female Bouvier that presented to UC Davis. It was a history of a breeding dog. Presented, it had been recently adopted by this owner and presented with right fifth gland, 5-centimeter ulcerated mass. That was a presenting complaint. On physical exam, the mammary chain, again, dogs have typically 5 glands, and so the right fifth gland did have that 5-centimeter ulcerated mass. We staged the dog, which routinely is chest radiographs, 3-view chest radiographs, as well as abdominal ultrasound, evaluation of regional lymph nodes by fine needle aspirate if they're palpable. This dog actually staged clean. No evidence of metastasis, so we sent them to the surgeons. They did, which is somewhat controversial, but recommended ovarian hysterectomy because this was an intact female dog, and removal of the right fifth, left third, and fourth mammary glands. On histopathology, you can see that we had certainly several tumors. The one that we were most worried about was this right fifth mammary gland, again, because it was large, it was ulcerated. We knew clinically that this is likely to be a bad behavior. Came back as tubulopapillary carcinoma with intraductal metastasis, which is another negative prognostic factor. And so based on this, traditionally we have used these things. So 50% of, roughly 50% of mammary tumors in dogs are benign. And so most of the time that we spend is trying to figure out which ones are not benign, the ones that we really have to worry about, and then the ones that we're going to have to recommend adjuvant, some sort of adjuvant therapy for. I realize this is quite small for you, but But just to let you know, the things that have been shown to be prognostic in the dogs, we look at spay status. We look at, the biggest things that we look at really are clinical stage. We look at grade, which is based on nuclear atypia, mitotic index, and tubular formation. And then we look at tumor size. There is some work, and Dr. Glaspy is going to go into this a little bit more than I am, but there is at least some work looking at what's been done in people as far as teasing out a little bit more and almost doing a little bit more of an individualized medicine, not only to predict how these tumors are going to behave, but also maybe even predict the best therapy for these patients. And so I put this up here, this is based on immunohistochemistry studies. I think we've got microarray studies that Dr. Glaspy is going to talk about, but it's the best, cheapest way that we have in a dog. These aren't routinely done, though, because they cost quite a bit of money, and most owners are unwilling to do these stains. So in this particular patient, again, we had the intraductal metastasis present. We had a large tumor that was ulcerated, and so we recommended chemotherapy. We don't have great studies in canine mammary cancer. We have a little bit more information in cats, but we still recommend chemotherapy with either carboplatin or doxorubicin. We offer that to the clients. We also have several clinical trials at UC Davis. We're quite excited about our clinical trials program. And in conjunction with Kit Lamb at the UC Davis Med Center, he had produced a nanoparticle Taxol, which we also offered to these clients. The reason why we need a nanoparticle Taxol is that dogs do not tolerate cremophor very well. And so traditionally, we've not been able to use that class of drugs in dogs. We are also part of the NCI Comparative Oncology Trials Consortium, which has several clinical trials for dog. It's multi-institutional. It's run through the Pediatric or Comparative Oncology program at NCI. The dog was spayed at the time of surgery. We also run into problems with using drugs like tamoxifen. In dogs, we see estrogen toxicity, and so even dogs that are spayed will develop stump pyometris oftentimes. We did offer potentially 3 to 4 weeks of radiation therapy because his tumor was incompletely excised. This particular owner declined additional therapy and really just wanted to do supportive care, and at the time when things got difficult, hospice and euthanasia when appropriate. She did want to follow the dog. We took thoracic radiographs about every 3 months. At 5 months, we diagnosed pulmonary metastasis, and at 16 months, there was bicavitary effusion, and the dog was euthanized. So that's my case.
So I'm John Glaspy, and I'm going to present a case of human breast cancer. This is a case of a 45-year-old premenopausal woman who presented with a right breast mass. A core biopsy showed that this was invasive ductal cancer mixed with a non-invasive component of in situ cancer. The mass was 2 centimeters on the breast MRI in the right breast, and the left breast was clear on the preoperative MRI. When she had her lumpectomy, the tumor was ER positive in 90% of the cancer cells. Its estrogen receptor was progesterone receptor positive in only 10% of the cells. And it was HER2/neu 3+ on immunohistochemistry, and on FISH testing had an amplification ratio, a number of HER2 genes compared to the number of chromosome 17s of 9.5, which is a dramatically amplified HER2 gene. She had her lumpectomy in her sentinel node. The invasive cancer was 1 centimeter only in size. The lymph nodes were negative, and her staging evaluation was also negative. She was treated very aggressively with 6 cycles of a combination chemotherapy regimen combined with a monoclonal antibody directed against HER2/neu. And after 18 weeks of that chemotherapy, remained on the monoclonal antibody for a total of 1 year. She had 5 weeks of radiation therapy as part of her breast conservation and 5 years of anti-estrogen therapy. Okay, so to sort of set the stage for where we're at and what the cutting edge of therapeutics in breast cancer is, we're in the middle of a paradigm shift. So we have been living with the results of the work of a giant in medicine in the 19th century named Virchow, who went to the trouble of going through thousands of human tumors and writing a book in which he set forth the postulate that under the microscope, cancers look most like the tissue they come from. So we should think about this as a group of diseases, with each disease rooted in its organ of origin. We still have that mindset in lay circles today. We talk about breast cancer as though it was a disease. Virchow's postulate was that breast cancer is a disease, that disease site is the logical way to approach the classification of human tumors. By the middle of the 20th century, by 1970s, we had reached an asymptote in terms of our ability to make progress in the treatment of the human disease using Virchow's paradigm. We were getting back very, very diminishing returns on huge investments in money and patience and time in terms of treatment of what we thought were diseases like breast cancer. And the way forward came when microarray approaches became available. For those of you who aren't used to looking at these things, this is on the left is what we call a heat map. And each column, each tiny column is a different human breast cancer, and each tiny row is a different human gene, and the RNA for that gene is reflected by the color of the square at the intersection of the particular tumor and the particular gene. If the square is red, there is a lot of RNA for that particular gene in that tumor compared to the average for all the tumors. And if it's green, there's very little RNA for that particular tumor, for that particular gene, compared to the average for all the tumors. And if it's brown, it's at the average. And you then take this huge amount of information. Initially, it was likened to trying to take a drink from a fire hydrant. The informatics involved in analyzing these data are actually more complex than the molecular biology of the test itself. But very quickly, and this has been repeated many times now, very quickly, the computers analyzing this data said there are two major groups of diseases here, and you can see that the first thing it did was divide the tumors and organize them into two groups. One group ended up being called the basal cancers, and the other group ended up being called the luminal cancers because it looks like the basal cancers arise from the basal cells in the breast that give rise to new epithelium when it's necessary, and the luminals arise from the lining of the breast duct. And then within each of those two, we find more than one subtype. In the luminal group, there were 3 subtypes identified, and in the basal group 2, in this particular analysis. There's ongoing debate whether there are 6 or 5 diseases hiding in breast cancer, but the debate is over on whether breast cancer is a disease. It is not. It's a group of diseases that arise in the breast that have very different molecular biologies. If you look at the gene expression patterns in different subtypes of breast cancer, you see that they're more different from each other in their gene expression profiles than you would think if this was a single disease. The case today, the ERB2B, the purple one at the top, and the purple group you'll see it's a very homogeneous group. Those are the HER2/neu positive tumors. And that's the subtype where we know two things. One, we know that they're going to do horribly if they are treated in the pre-21st century way of treating them. These women have very high risks of recurrence, and that's why a node-negative small tumor patient received the relatively aggressive treatment she received. And the second thing we know is that if we block that receptor, this is a gene that encodes a receptor, with a monoclonal antibody, they become very sensitive to chemotherapy and become one of the best kinds of breast cancer. This is instructive, and it tells us that there's likely to be a lot of pay dirt in further attempts to target therapies based on subtype. And I'll stop there.
That's great. Yeah, I think what we're going to do, actually, why don't we have, John and Robert, why don't you sit down now and have a brief conversation, okay. And then we'll hold questions until after our osteosarcoma case. But we'd like to just, while it's fresh, have you guys discuss this a little bit.
So do you want to lead off, or?
Sure. I guess one of my things in looking at your slides, one of the things that we have, when we started to look at immunohistochemistry and trying to break down the different subtypes, one of the things, and the study is not very well powered, but one of the things that came out of that study was the HER2 dogs didn't behave. They were the only group that didn't behave like the human side. And I wasn't sure, so when you treat with monoclonal antibodies towards those HER2 expressing tumors, you're also treating estrogen therapy as well, or?
About half of the HER2 positive cancers will also express estrogen receptor. And in humans, if you treat a HER2 positive cancer that's also hormone positive with hormonal therapy, the hormonal therapy fails. If you block the HER2 and then treat them with hormonal therapy, the hormonal therapy is effective. So we tend to use hormonal therapies in HER2 positives when they're ER positive, but not if they're ER negative, and not without also blocking HER2. So that's number one. Number two, I was also taken by that difference on your plot there in terms of HER2 prognosis. It was IHC, and one thing that we've learned in humans is that IHC is not very reliable for HER2 testing. The pathologist is asked, does this look medium brown or dark brown to you? And if he says medium brown, that's negative, and if he says dark brown, that's positive. And there, you know, with amplification ratios, you can put a finer point on it using FISH.
Yeah. We do certainly have the technology available. There's canine microarrays that we certainly can do these studies at quite an expense. The problem is trying to find the funding to do it.
That may be the biggest difference between adult or human and veterinary oncologists, is the amount of money we spend. But
correct. Yep.
I just have a quick question. There were recently, the New England Journal had a wonderful piece looking at dog genetics and opportunities for translational investigation. And I'm curious, Robert, if you'd comment on dog breeds that have a tendency to get mammary cancer, and what you think we can learn on the human side from those animals.
Sure. So, you know, we've known for quite a while, so certainly here in the United States, where we spay quite a bit, most of the dogs are spayed, we can reduce the chance of mammary cancer. If we hit them before their first heat, we reduce it by over 99%. If by a second heat, it drops to about 92% reduction. Beyond that, and this is kind of the older data, but beyond that, there's really no protection from spay. And so we've known that for quite some time. We also know clinically that the size of the dog actually is predictive of how likely the tumor is supposed to be or going to be metastatic. So again, in dogs, it's about 50-50, benign versus malignant tumors. small dogs tend to get more benign tumors, whereas the larger dogs tend to get more malignant tumors. There are a couple specific breeds, so now as we're identifying some of the potential either mutations in dogs, breeds, for example, BRCA or BRCA1 mutations that were found in a family of English Springer Spaniels, I believe, in England. And, you know, other dogs like Shih Tzus, even though they're a small breed dog, they tend to also potentially have BRCA1 mutations.
Great. All right, and we're going to go ahead and move on to our osteosarcoma cases. I want to go ahead and introduce our human oncologist, although, again, we're going to have Dr. Rebhun start. We're going to be hearing from Dr. Noah Federman. Dr. Federman is the director of the Pediatric Bone and Soft Tissue Sarcoma Program here at UCLA's Jonsson Comprehensive Cancer Center and Mattel Children's Hospital here at UCLA. He is assistant professor of pediatric hematology oncology.
Moving on to osteosarcoma, which I think is a really good model, and lots of people have looked at this for years. You know, even down to the molecular level, the clinical level, this disease is quite similar in dogs and in people. So this dog presented, and it's not uncommon to have a one-day history of lameness. Depending on what breed of dog this is, you know, certainly when we get into the large breed dogs that are more predisposed to osteosarcoma, you know, we have Great Danes that come in. If they're limping, we usually, the first thing we do is take a radiograph because we're suspecting osteosarcoma. And this is actually not a diaphyseal lesion, metaphyseal, I just saw that. So one day history of lameness in the right hind, took a radiograph and we saw a mixed proliferative and lytic lesion, the metaphyseal section of the right tibia. Fine needle aspirate, so a lot of times we'll take these dogs up to ultrasound. We'll actually look for a break in the cortex and do a very quick fine needle aspirate. We very rarely get a diagnosis of osteosarcoma on that, but we most oftentimes do get a diagnosis of sarcoma. So it doesn't usually tell us the difference between osteosarcoma, synovial sarcoma, or other sarcomas that could arise in bone, like hemangiosarcoma. In this particular case, although there's been a lot of work done, started at Colorado State University for limb salvage procedures. Limb salvage can be done in dogs. Usually the best candidates are going to be forelimb, which 60% of dogs that present with osteosarcoma are going to have forelimb involvement. In the back leg, limb salvage surgeries don't do very well. And actually in most dogs, I would say about 98% of dogs with amputations do extremely well, especially hind limb because they carry about 60% of the weight on their forelimbs. Most dogs don't really care. They almost have an extra limb built in with fore. And so we usually go right to amputation, or at least offer that to the owners. We did do an amputation here. The dog stage clean. We took chest radiographs. We always offer nuclear scintigraphy or bone scan. It adds a cost of about $400 and slows down the surgery a little bit. But again, a lot of these decisions are cost-driven based on what the owners can afford and would like to do. So this dog was staged with abdominal ultrasound, 3-view chest radiographs. Owners declined CT of the chest and also declined nuclear scintigraphy. Again, a histopath came back as osteosarcoma. What we typically prepare these folks for is, with amputation alone, median survival time is about 4 to 6 months. If we only do amputation, about 10% of dogs are alive at 1 year, and less than 5% are going to be alive at 2 years. So despite the fact that we can't find metastatic disease at the time of diagnosis, these dogs, the vast majority, are harboring micrometastases. This dog, like I said, we did chest x-rays, thoracic radiographs prior to amputation. When the dog came back, had some complications, but about 3 weeks after amputation, we went ahead and repeated the thoracic radiographs, and I'm not sure if I have, let me see. So in 3 weeks' time, this dog had developed a met that we had not seen previously. We may have been able to pick that up on CT scan, but it wasn't visible on radiographs 3 weeks before. So at this time, you know, if they don't have gross metastatic disease, if we add in chemotherapy, which traditionally now is single agent carboplatin, with that, median survival time is anywhere, one report of 320 days, some are up to about 14 months. The issue with this case is we had gross metastatic disease, and so median survival time for that is typically around 60 days. These owners wanted to be particularly aggressive. They did, so we offered standard chemotherapy with carboplatin. The dog progressed on that therapy. Again, I said we're very interested in clinical trials at UC Davis. Dr. Carlos Rodriguez is running a study looking at ifosfamide and inhaled gemcitabine. Some of his inhaled gemcitabine work has also been done at MD Anderson. And he's showing in dogs that you can upregulate fast ligand in these tumors. And again, the dog progressed with all of these different treatments. 5 months post-amputation, dog presented to us progressively decreasing activity level and lethargy over the past week. It actually was down and refused to walk. The owners were assuming that this was metastatic disease, and they really thought that that was the end. They came in, we felt on palpation, we recognized pain and peripheral edema of the 3 remaining limbs. Took these radiographs and actually saw a marked periosteal reaction consistent with what we call hypertrophic osteopathy in dogs, which is also a disease that, similar to humans, hypertrophic pulmonary osteoarthropathy. It's a very painful thing. We don't really have great treatment for it. These owners wanted to continue to treat, so the only thing left on our list at that point in time was to do inhaled IL-2 therapy. Fairly expensive. It's about $1,300 for a 3-week supply. It's actually human Proleukin. And this work was done in the 90s, actually. David Bale and Greg McEwen, I think, and Sean Khanna, who's at NCI right now, they were anesthetizing dogs and essentially giving them inhaled IL-2. And 2 out of the 4 dogs that had osteosarcoma metastases, so half of those dogs had really good responses. But the issue is that it was thought difficult to have dogs do inhalational therapy and have to go through anesthesia every day to get these treatments. And one of the things Dr. Rodriguez had done at UC Davis is basically figured out a way for a nebulizer to be able to train dogs to sit there for their 20 minutes of treatment and get treated. And so we ended up, I went backwards, didn't I? We went ahead and treated with the IL-2. Actually, surprisingly, the dog's pain associated with hypertrophic osteopathy was greatly improved. And in November of 2011, when we started, to June of 2012, we actually saw a response to the IL-2 in the gross disease setting. And they've continued to they're still there, but they're not growing. And for a dog that was supposed to have 60 days median survival time, that's pretty good.
So I'm going to talk about a case of osteosarcoma in humans, and I think it's very important just to start out with some basic epidemiology of pediatric and adolescent cancer, and that is that this is incredibly rare. There are about 10 to 12,000 cases per year of cancer in children, adolescents, and young adults. And that really pales in comparison to the frequency of breast cancer, for instance, which is about maybe 200,000 cases a year, plus or minus, in adults. For osteosarcoma, we're even dealing with a rarer cancer. There are about 450 cases per year in the United States in adolescents. And this is incredibly rare in comparison to dogs, where it is much more common. So I think the comparative aspects that we can take from human and animal medicine for cases, specifically diseases like osteosarcoma, we have a lot of work to do and have done so already. So this is a patient of mine. He was 17 at the time. He's now 21. He just turned 21 2 weeks ago. He is a great pitcher. He was throwing 95 miles an hour at 17. He was being recruited by Cal State Fullerton with a full ride, and he also was being scouted by the minor leagues, several teams, including the Mariners. He was having pain around his knee joint when he was pitching, and you can see that where that arrow is. And really, this was going on for a period of months, and like all active adolescents and young adults, this was really was assumed to be related to his pitching, a musculoskeletal sprain and strain. But after several months, this pain was really progressing to the point that it was waking him from sleep, was not being relieved by acetaminophen and NSAIDs, and then he started to develop a firm swelling above his right knee. And so at that time, plain films were done. There must be a pointer on this thing. Let's see. Yeah, there is. Okay, and so this is the radiograph, the plain film that was done, and what you can see here for both human and veterinary medicine, is I'm sure you're used to seeing, is that periosteal reaction, which is a marker of something very aggressive and potentially malignant going on in the bone, and this sort of sunburst reaction and hair-on-end appearance here, which is really pathognomonic for a malignant bone lesion, and in a young adult like this, and in this location, would be until proven otherwise, osteosarcoma. At UCLA, we do core needle biopsies 90% of the time and get a successful diagnosis about 90% of the time. We prefer using this modality because it really is minimally invasive. But again, we use core needles rather than fine needle aspirates because the fine needles don't give us the architecture that we need to make the diagnosis. And this is what we get in this patient. You get this malignant osteoid, this sort of fine, irregular osteoid that is being formed within the medullary cavity of bone, and then just malignant spindle cells here. This is conventional high-grade osteoblastic osteosarcoma. So the staging work up here for humans probably exceeds the entire cost of care in animals. And so the plain films of the primary are relatively cheap. The thoracic CT, which we do because about 20% of osteosarcoma patients will show up with clinically evident metastases, and most of those will be within the lung. We do an MRI of the primary lesion, and this is really important because although we can get most of the information from X-ray and even CT, what this tells us is where we need to operate and where it is safe to make a cut to remove the affected bone. Because the X-rays and CT may show us that this is the only affected area, but what you'll see here is that tumoral edema is coming up the medullary canal of the bone and in the bone marrow, and these are all malignant cells here. So this is really important in the initial sort of staging workup of these patients. We get a bone scan, and a bone scan, as Robert was mentioning, is important because of the patients that have metastases, 80% of them will have pulmonary metastases and about 20% will have bone metastases. This patient had localized disease only in this area in the distal femur, which is the most common location for osteosarcoma, but no bone metastases or lung mets. And then something that we're exploring here at UCLA and some other centers is using 18-FDG PET-CT, fluorodeoxyglucose PET, combined with CT imaging of the whole body. We found that it's more sensitive to pick up bone metastases, and we've also found that we can really judge the response to therapy for these patients, hopefully in the future that we can tailor their therapy based on their response. So this is really had been and continues to be the hallmark of therapy for osteosarcoma and all other sarcomas, and that is that you cannot cure a patient without successful local control. Local control means removing the tumor or radiating the tumor. In osteosarcoma, we don't generally use radiation because it's not truly sensitive. But, you know, and as my orthopedic counterparts and the chair of orthopedics now at UCLA will remind me that I was not even in the womb in 1970, that really what we did for all of these patients, 100% of these patients got amputation. So if you had a tumor in the ankle, we cut here. If you had a tumor in the knee, we cut above the knee. If you had a tumor in your thigh, we cut at the hip, and so on, and the levels continue to go up. But in spite of that, almost 100%, 90% of these patients recurred within 6 months, recurred both not only locally but with lung metastases. And so it was clear that we weren't doing something right. Even though they didn't have clinically evident metastatic disease, these patients would show up with clinically evident metastatic disease later on. The hallmarks of local control are really making a cut safely above the tumor and safely above the tumor, and what we are really striving to do is limb salvage for these patients. So we're no longer doing amputation in most of our patients, and we put in either a titanium or chrome endoprosthesis with steel, or we'll use allograft bone. And depending on what center you're at, we may use one or the other based on surgical preference. I think as a pediatric oncologist, this has been one of our true successes in therapy, and that is with the addition of chemotherapy, which started in 1970. We started to get really a large improvement in survival, long-term survival for these patients. And Dr. Cade in Edinburgh in 1955, you know, started and basically concluded the meeting by saying, gentlemen, if we operate on these patients with osteosarcoma, they die. If we don't operate, they die. This meeting should be concluded with prayer. And that was where we were until 1970 when we started using chemotherapy. And as you can see, you know, in 1970 when we started adding methotrexate into our treatment regimen, the survival started to increase substantially. Now adding combination therapies like adriamycin, doxorubicin, cisplatin, ifosfamide into the treatment plan, we're now approaching about a 70% survival for these patients with disease in only one location, localized disease. And this is an example of our sort of standard treatment for these patients with methotrexate high dose, doxorubicin, cisplatin, and this goes on for about 9 months to 1 year of therapy. So it is a substantial therapy. These patients, I think one of the differences between humans and animals, not just the cost, is what we're willing to put our patients through, and that is and the supportive care that we're able to do, because this really would be impossible, I think, in a canine. Our failures, I think, are just as important, and you know, we have really now plateaued in our survival for osteosarcoma, localized osteosarcoma, at about 70%. And I think what could be worse than telling your patient that you have osteosarcoma or any cancer is really being told that after going through all of this treatment and surgery, it has now come back and it has spread to other locations. And so, in fact, this patient who we thought was going to be a long-term survivor about 6 months ago presented with this lesion in his lung. We resected it, and it turned out to be osteosarcoma again. So about 30 to 40% of our patients with localized osteosarcoma will develop a recurrence, and the survival at 5 years is 20 to 30% shown down here. That has not changed in the last 30 years. We are still at 20 to 30% despite millions of dollars in clinical trials, new chemotherapeutic agents. We still don't really have a good understanding of what to do with these patients that have either metastatic disease at diagnosis or who develop recurrence or metastases later on. We do understand that there are patients that can be long-term survivors, and those patients need to have a complete surgery to remove the sites of disease. That if you have 1 metastases, you do a lot better than if you have 10 metastases. And then if you have a recurrence or a development of metastatic disease 2 years later, you're much better off than had you developed it within 1 year of completing treatment. the use of chemotherapy for these patients now is quite controversial. So, here at UCLA and in collaboration with some other centers, we're running a clinical trial for patients like this, and this patient is enrolled in that trial, putting on a targeted therapy, a biologic targeted therapy, targeting a Sarc kinase, which is a tyrosine kinase, which we know inhibition of that kinase causes apoptosis, cell death in osteosarcoma and other cancers. And so this patient is on this, and in fact, it's a randomized trial. And there are those that would say, well, is that ethical to put a patient on a randomized trial to treatment or placebo? And the answer is we still don't understand. We don't know if there is any benefit to adjuvant therapy in this setting. So with that, I'll conclude. So I think there, as I'd mentioned, there are a lot of, osteosarcoma in humans and animals is actually quite similar in the presentation, in fact, the genomic signatures, in some of the pathways that are dysregulated. And one of the areas I think it would be really important to have crosstalk, and that already exists at places like the NCI, is just in the sheer numbers that affect dogs versus humans, where we're really dealing with 450 cases per year, and perhaps running these clinical trials in dogs to learn for humans and vice versa.
Yeah, I agree. I mean, this is certainly a disease where, our best guess is that we see about, not at Davis, but nationwide, we see about 8,000 cases a year. Wow. And so we do have this opportunity. The other thing is with financial limitations, many owners would like to do treatment, but can't afford these treatments. I think there are enough things that we do differently with dogs that actually provide an opportunity for us to maybe better answer questions. The fact that we amputate right away, we can look at pharmacodynamic endpoints, biologic endpoints. If we do a treatment, we can remove, so for certain clinical trials that we're involved with, we can perform a treatment and amputate 2 days later to see histologically if that treatment did what it was supposed to do. And for targeted therapies, that's quite important. So we do have a little bit more leeway to perform these studies. The other thing is the vast majority of dogs we're not curing cancer. So we don't cure 70% of patients. And so we get this population, we're looking at about a 25% survival rate at 2 years. That's with our aggressive chemotherapy. And so eventually the majority of these dogs relapse, and we have an opportunity to treat metastatic resistant disease, most often in the lungs, which is exactly the situation or you would like to get more information from. And the last thing I'll say, and before I kick it back to you, is the other opportunities that we have are to take some of these perhaps novel therapies that may be tried in resistant metastatic disease, where we're asking a lot of these new investigational agents. What about putting them as first-line therapy? Do they have efficacy as first-line therapy, or in combination with our standard of care, could they actually be better used there? And that's something that I think we're excited about with the IL-2, is that this could perhaps be something that if it's one of the very few things that we've ever seen work in a dog on metastatic disease, in the gross disease setting. And if we can, most of us in cancer really would like to use chemotherapy on, or any kind of adjuvant therapy on the least amount of disease as possible and give it the best chance to work. So we're excited to potentially be looking into doing an IL-2 trial on dogs immediately post-op.
I think that what we should all remember in terms of also studying human osteosarcoma, and I study it also in the laboratory, where we use a mouse model which is really a immunodeficient mouse, where we inject osteosarcoma either into the tail vein to develop lung metastases or into the subcutaneous tissue, and these are really not good models for treating, for developing therapies for humans. And here we have a naturally occurring model that mirrors human osteosarcoma. And I think the potential now for really screening libraries of drugs in a model that mirrors humans is tremendous, where we can take 100 drugs and screen it in an animal with naturally occurring osteosarcoma to see if we get a signal. And we still have to do the mouse experiments, but I think that is really a great place where we can really make enormous strides in the treatment of human and dog osteosarcoma, where you have thousands of animals a year that are being diagnosed with this.
We'd like to take a couple of questions, maybe one or two breast questions, and then one osteosarcoma. We're going to have to move a little bit quickly, so go ahead.
Thank you. Recently, there's been a lot of evidence of the microenvironment, especially in breast cancer. Do you see a day where we'll have to biopsy the microenvironment, the stroma, as well as the biopsy to develop some of our therapies?
Well, we can't not biopsy the microenvironment. It's part of all breast biopsies, right? It's part of all breast samples. The issue has been, actually that has made some of these genomic approaches more difficult because you have to make sure you're testing the tumor cells and not the microenvironment cells if you're interested in the tumor cells. So we already do it. The issue is separating them and then how you cone down the technology for coning down on individual cells and doing molecular tests on them.
A side note on that is with the dog, we also, and we're running an NCI trial right now where we're able to perform multiple biopsies on the gross disease setting. So in cases where the tumors are unresectable or the owners are unable to afford resection, it does allow us to do multiple sampling, and certainly that could be looking at the stroma as well.
Yeah.
Less of a question and more of a request for a commentation. So when you're looking at trying to translate therapies from humans to animals, I know in human medicine, a lot of the therapies are becoming more molecularly targeted. So mutated BRAF and melanoma, BCR-ABL leukemia. If we don't understand the molecular workings of a cancer in animals, is that going to become more difficult to translate compared to your more generic chemotherapies like cisplatin and whatnot?
First of all, yes, it will. The second thing is that you have to be careful, even if you knew that a given cancer in an animal was BRAF mutated, you have to understand that, for instance, a significant fraction of human colon cancers have the same BRAF mutation that melanomas have and are totally unresponsive to the medicine that works in melanoma. So you're going to have that other validation issue that even if you get the molecular hurdle cleared, you still have to validate it because the dogs are different, or the elephants, whatever.
Yes, and that's a lot of the research that a lot of people are doing right now. You know, we have a national canine tumor bank that UC Davis is involved with. We look at these things, and so of course, you know, humanized antibodies are not going to be very effective in the dog, especially after the first dose. And so we don't have the ability or the funds in most cases to come up with a canonized antibody. We are actually running a clinical trial at UC Davis with a canonized antibody against CD20 in lymphoma. So these things, the technology is there. It's whether or not it's going to be in a company's best interest to develop those and how well they're going to work. We do also have some small molecule tyrosine kinase inhibitors that are now approved for use in dogs. And so, you know, we can look at these. We have about 15 to 20 cell lines, canine tumor cell lines at UC Davis that we look at. And so if we are going to investigate a new drug, yes, we have to look and confirm that these targeted therapies are actually going to work.
This is fascinating to me as a clinician, and I'm wondering whether there is this increased incidence of osteosarcoma or breast cancer in wolves and in hunting dogs and coyotes and wild canids that aren't really in a domestic environment.
Yeah, I mean, they definitely can get it, but not at the rate that we're seeing. You know, we know that this is a disease of large breeds. We know that there are certain breeds that are predisposed to this. Golden Retrievers, Great Danes, Greyhounds, and in small dogs, this disease usually does not occur. 85% are going to be greater than 30 kilograms. And in those dogs, most are appendicular osteosarcomas. In the smaller dogs that get osteosarcoma, they're usually axial, and they're most oftentimes less metastatic. It's interesting you bring up wolves. I don't know this. I don't want to take up too much time, but so recently, and I think a few years ago now in Science, they looked at dog size, and that seems to be correlated with IGF receptor, insulin growth factor receptor 1. And they actually can dictate the size of the dog, and they've tracked that back to Middle Eastern wolves or something. But it is something that I think is fascinating, because I've mentioned in both the mammary and osteosarcoma cases that size seems to be predictive of behavior. Whether that has to do with IGF-1, I don't know.
So if I can comment on that, I didn't mention in my talk that there aren't necessarily specific sort of ethnic risks for developing osteosarcoma. Caucasians seem to be getting it a little more than African Americans or Black descent or Latino or Asian. But what we do see is that patients that get osteosarcoma tend to be big, just like the large breed dogs. And there's been a lot of epidemiology research that's been controversial in this field, but I can tell you in a clinic of 50 osteosarcoma patients, when 90% of them are taller than me, you know, and they're 16 years old, I think you can tell that these are patients that are tall patients. They had big growth spurts, and that seems to be what we see in osteosarcoma and another bone cancer called Ewing sarcoma. These patients tend to be tall. Whether you could classify them as large breed is a different story. But what we're also finding out, which I think is important, is that a lot of these patients with both osteosarcoma and Ewing sarcoma, actually mostly in Ewing sarcoma, seem to have dysregulation of the IGF pathway, both germline and in their tumors. And in fact, that's some of the therapies that we're developing now are IGF blockade. So it's sort of an interesting paradigm. The one difference that I think is interesting is that our patients tend to get osteosarcoma in the second decade of life, which is their growth spurt, the onset of puberty and menarche. But for dogs, my recollection is it's actually much later, in dog years to human years, whatever that is.
There's a small peak between 2 and 3 years of age, and then it gets up to 7 to 9, which is a middle-aged to older dog.
Thank you. Absolutely fascinating. Really appreciate it. Thank you.